Buenas tardes, vamos a dar
Good
inicio
afternoon. We're going to start to the webinar Science in Action for Better Cardiovascular Health, the cases of Cuba and Mexico. And we would like to thank all of you, all of the participants and the speakers for being here on time. This session has simultaneous translation in Spanish, Portuguese, and English. You may go to the toolbar at the bottom of the screen to select interpretation, and then you select the language that you want to listen to. As well, in the chat box, you may send greetings and as well just putting your name and as well from the country. If you want to send some questions to the speakers, please use the Q&A section that as well is located at the toolbar. We'll try to answer to all of your questions as we develop this webinar and as well during the Q&A session that we have scheduled for this. Finally, we would like as well to let you know that this webinar is being recorded and is broadcasted at the same time using the PAHO YouTube channels. After this, we are going to be having this recording at the webpage of Hearts, and it's going to be shared to all of the participants. Welcome, welcome again. I would like to give the floor to Dr. Pedro Ruiz. Thank you very much. Thank you very much, Jenny, for your presentation. And good afternoon, colleagues, or good day, or good night, good evening, depending or from where you're looking at. And we start this webinar, we would like to say, we hope that you are doing well as much as possible during these complicated times of the pandemic of the COVID-19 that we know that are impacting a lot of countries of this region, and that as well is causing damage. However, today, well, we are looking and just finding sometimes just to meet to another webinar that is a very relevant topic for the health of this region and the world. We're talking about cardiovascular diseases. That's the first cause of death and disability in this region. So today, this seminar, this virtual seminar of the Heart Initiatives at the Americas is titled Science in Action for Better Cardiovascular Health. And we are here introducing and presenting the cases from Cuba and Mexico. And immediately, I would like to send a message that is very important for our audience that is watching us. In Cuba and in Mexico, we've had the opportunity of gathering two visions of this problem. One side is the science, people that are in charge of finding the determinants of these factors in the population, explaining the causes of these cardiovascular diseases. And on the other side, as well, we have the people designing the health services and health systems to cope with this. That's why from one side, we see the connotation of having the science, and on the other hand, the answers without these answers meant that it's not a science. I think that is a very interesting message that we need to convey. First of all, we're going to be having a group of relevant scientists that for a lot of years have been working in these topics and that are just showing two world-class studies. And in a second section, we're going to be having the scientists of implementation. This means that people interpreting this data, and as well they use it every day in health services and defining the best intervention to mitigate the cardiovascular disease effect and to reduce the effect of the CVDs and as well risk factors. So without further ado, after sending greetings to all of you, of course, we are in a pandemic of the COVID-19, and that's why we have to pay more attention to chronic diseases because we know that the main victims of complications and death due to the COVID-19 is related to chronic diseases, in particular with hypertension, diabetes, in general, CVDs. So this webinar is so important today. So in this first section, I have a pleasure of introducing a group of researchers, as I said, world-class researchers, and they are going to be talking in this first section. The University of Oxford has been just with several countries of the world, the development of these prospective cohort studies, and today we would like to just to show the cases of Cuba and Mexico. So in our first speaker, I would like to welcome Dr. Jonathan Emberson. He is a professor of medical statistics and epidemiology of the University of Oxford. that has been so kind of here with us to present, first of all, their reach and the methodology of the studies that we're going to be looking at. As I said before, the scope and these prospective cohort studies from Cuba and Mexico, in charge of Dr. Jonathan Emberson. He's the professor of medical statistics and epidemiology from the University of Oxford. Please go ahead.
Thank you. It's a tremendous pleasure to have been invited to give this presentation today, to introduce to you these two fantastic prospective cohort studies, the Cuba prospective study and the Mexico City prospective study. Before describing these two studies in particular, I'd like to briefly talk about the value of cohort studies in general, and in particular, the value of establishing cohorts in different populations. And I'd like to start by asking the question, why do we need studies in different populations at all? Well, complementary studies, of course, yield opportunities for replication and for combined analyses. Diseases that are rare in one population and hence difficult to study may be common in another. Genetic heterogeneity between populations may help to assess health-related variants. And of course, studying different populations gives you the opportunity to study a much wider range of exposures, such as adiposity in rural India versus the UK versus Mexico, for instance. And one final note is that to assess the full effects of different risk factors, it's heterogeneity that's important, not representativeness. If we want to fully understand the causes of disease in people, we should study as many different types of people as possible. Now, the next point I'd like to make is that when it comes to prospective studies, size really does matter. To illustrate this, I'm going to show three sets of results from randomly selected samples of 5,000, 50,000, and 500,000 participants from the Prospective Studies collaboration, which was a meta-analysis of studies from mostly high-income populations. With 5,000 individuals, about the size of the original framing study, you really can't tell what the relationship is between blood pressure and coronary heart disease mortality, overall, let alone at different ages. With 50,000 individuals, the relationships become a lot clearer, but there are still uncertainties. For example, is there potentially a J-shaped association at younger ages? Or at older ages, is the relationship potentially flat? But by the time you increase the sample size to 500,000, the relationships become really clear, with strong log-linear associations between blood pressure and CHD risk at all ages, at least down to a level of about 120 millimeters of mercury. And we're extremely fortunate that the speakers you'll hear from next realized the importance of study size over 20 years ago when they established their own prospective studies. I'm going to briefly describe the main features of those studies to you now, but for full details, I'd recommend you read the cohort profiles that were published in the International Journal of Epidemiology some years ago. So the Cuban prospective study. Between 1996 and 2002, the Cuban prospective study recruited 150,000 adults aged 30 years or over from one of 5 Cuban provinces, which was selected to maximize the potential to investigate the associations of major risk factors with premature death. In each province, a subset of medical offices was chosen at random, and then local staff from those offices systematically visited all households on their register, inviting all adults aged 30 or over to take part. And the response rate was excellent. About 3/4 of eligible adults agreed to take part. The baseline interview involved a short, one-page paper questionnaire, which captured information on education and occupation, smoking and drinking, and prior disease and medication. Height, weight, and blood pressure were then measured. Subsequent linkage has been to the National Death Register, with causes of death coded to ICD-9 and ICD-10. Between 2006 and 2008, a resurvey of 20,000 participants was done, chiefly to allow estimation of within-person variation in risk factors and correction of the bias that can arise as a result when looking at associations with baseline levels of risk factors rather than usual levels, something known as regression dilution bias. Now, a key feature of this cohort that makes it different from most of the populations is the very high prevalence of smoking from early life, even before the age of 10, thus allowing for the full effects of smoking from childhood to be studied. A couple of years after the Cuban study started, the Mexican study did. Between 1998 and 2004, 150,000 adults aged 35 years or over were recruited from 2 districts in Mexico City. Again, more women than men were recruited, with 2/3 of the cohort female. In this study, information at baseline was captured using an electronic handheld data recorder. Information was collected on socio-demographic characteristics, lifestyle characteristics, prior diseases and medication, and reproductive history for women. Height, weight, waist circumference, and hip circumference were measured, as was blood pressure. In addition, a blood sample was taken and processed locally, from which plasma and DNA were extracted and are now in long-term storage. As in the Cuban study, linkage is to the National Death Register, with all deaths coded to ICD-10, and, also as in the Cuban study, a resurvey of 10,000 participants was completed between 2015 and 2019. 2 key features of this population are the high mean BMI at recruitment, which was on average 29 kilograms per meter squared, and the high prevalence of uncontrolled diabetes, with 1 in 5 men and women having a diagnosis of diabetes by age 60, and mean HbA1c in those with diabetes being 9%. Over the years, both of these studies have published important and novel findings on the relevance to premature death of major disease risk factors, including smoking, drinking, adiposity, diabetes, and of course blood pressure, which you'll soon hear the results of. So in summary, the Cuba and Mexico City prospective studies are 2 of the largest cohort studies of Hispanic populations ever to have been done, and both already have more than 20 years of follow-up. Both have published important and novel findings of the relevance of major disease risk factors in their respective populations, and these studies illustrate the value of having cohorts in different populations which vary in disease prevalences and ranges of exposures. Thank you.
Muchas gracias al profesor Jonathan Emberson.
Thank you very much, Dr. Jonathan Emberson, that is a professor of medical statistics and epidemiology of the Oxford University, for talking about the studies from Cuba and Mexico. And I think that before going to the next speaker, I would like to say that we're talking about a cohort study of more than 150,000 individuals. And the message that I could convey is look for these studies. If you are watching this, go and look for these studies. They are available, and it's very interesting for you to read those studies and to assess those studies. And then immediately, I would like to go to the first speaker from this group of results. That is, Dr. Emberson talked about the methodology of those prospective studies, and now we're going to see the results. And for this, here with us, we have Dr. Nuris Armas Rojas from the National Institute of Cardiology and Cardiovascular Surgery from La Habana, Cuba. And she's going to talk about the blood pressure and CVD mortality in Cuba. Please go ahead, Dr. Alma from the National Institute of Cardiology at Cuba. Go ahead. Good afternoon. My name is Dr. Nuris Armas from the National Institute of Cardiology and Cardiovascular Surgery from Cuba, and I'm a member of the National Commission of Hypertension and Coronary Heart Disease, and I represent the cardiovascular prevention for the National Group of Cardiology. Thank you very much to Hearts for inviting us to this webinar. So today we're going to talk about the following study: high blood pressure and other risk factors and cardiovascular mortality in Cuba, prospective study of 146,556 participants. In 2013, the World Health Assembly from the WHO adopted the global objective to reduce at a 25% premature mortality due to non-communicable diseases by 2025. Several WHO targets were aimed at cardiovascular mortality, including reduction of the prevalence of high blood pressure and as well stopping the prevalence of diabetes and obesity. On the other hand, as well, cardiovascular diseases represent around 1/3 of all the premature deaths in Cuba. However, The importance of blood pressure, diabetes, and the body mass index to CVD mortality in this population remained unclear, and carrying out this study was necessary.
Como podemos observar en esta diapositiva.
As we can see in this slide, for every 20 millimeters of mercury and an increase of SVP, the risk of dying is going to double. It may be for coronary heart disease and as well for strokes. What we can see here, generally speaking, is that for every 20 millimeters of mercury and an increase of systolic blood pressure, the risk of dying for a CVD is doubled, and the mean age was 69 years old when dying, and as well the strength of association increased in younger ages than in older ages. But we didn't have evidence that the strength association would change according to the sex, gender, smoking, or from the subsets of the coronary heart disease and some other cardiovascular diseases. As we can see in this chart, this pre-diagnosed diabetes at the beginning of this study was associated with around the double of the risk of dying due to a CVD compared to those having diagnosed diabetes. The strength of the association was slightly weaker at the age of 70 to 79 years old than in younger ages. But as what happens with systolic blood pressure that is usual, those associations didn't change according to the gender, smoking, or among the first subsets of cardiovascular death. So in this chart, we can see that in the CVD mortality analysis in relation to the BMI, usual BMI, mortality was lower around the BMI of 22.5. There was a strong positive association above this level. So in this chart, we can see that for every increase of unit of BMI above 22.5, the risk of CVD mortality was around the double. We didn't have evidence that the strength of this association would change according to age, gender, or smoking, but it was weaker for the strokes than for coronary heart disease or some other cardiovascular death. As we can see here in this chart, there was an association around a linear of the BMI with SVP and as well with the prevalence of diabetes. So this chart shows the association of the body mass index that is usual and as well cardiovascular mortality with more adjust for diabetes and SVP that may be mediators of this relation. The association changed a little bit later after having an additional adjustment for diabetes. However, as well for the systolic blood pressure that is usual was attenuated almost completely. 95% of the association with BMI was due to its effect on SVP and diabetes. So here we can see that an increase SVP, diabetes, and a raise BMI or more than 22.5 represented almost 30, 15, and 20% of premature deaths. It means that is before 70 years. So, as a conclusion, we think that these fractions that may be attributed to the population would equal to an excess in CVD mortality around 5,000 deaths due to a high SVP 2016, then diabetes, and 3,000 to an increased BMI between 35 and 39 years old in Cuba in 2015. This large prospective study provides direct evidence for the effects of blood pressure, adiposity, and diabetes on CVD mortality in Cuba. Overall, CVD mortality doubled for each increase of 20 millimeters of mercury and higher usual SVP or previous diabetes or more 10 units higher than the usual BMI. despite comparatively low levels of these risk factors. According to international standards, the strength of their association with cardiovascular death means that they exert a substantial impact on premature mortality in Cuba. As the levels of these risk factors increase in Cuba, so will their importance as determinants of premature cardiovascular death unless further efforts are made to address cardiovascular risk in this population. Thank you very much. Thank you very much, Dr. Almas in Cuba, for talking about this interesting study that again just shows the importance. Look at this. And then let's talk about this. The importance about systolic blood pressure, diabetes, and as well the body mass index as the determinants of cardiovascular mortality in Cuba. They didn't talk about tobacco, but later on we're going to talk about this topic as well with the importance that we have in this study and as how you saw. Now, next we have another study that we are presenting today is from Mexico City. That is blood pressure and mortality to specific cases in Mexico City. This is one of the other studies of the large cohorts of this study. I'm very proud to have these type of studies. We have another one, of course, but we are talking about the cases of Cuba and Mexico City. And now I would like to introduce Dr. Jesús Alegre Díaz from the Universidad Nacional Autónoma de México that is going to talk about the case of this Mexican study. Please go ahead. Thank you very much for your attention. My name is Dr. Jesús Alegre Díaz, and I'm professor of the Universidad Nacional Autónoma de México. And for me, it's a pleasure to be here in this important meeting from this Pan American Health Organization to show you this prospective study of Mexico City. This is a cohort, as it was mentioned by Dr. Emberson, of 150,000 adults from 35 years or more that have been following up from 1998 to 2004, which was the baseline recruiting up to this moment. In 2015 and 2019, we carried out the resurvey of 10,000 survivors, and mainly just to correct the regression dilution bias, and as well just to make some improvements, just to take some variants that we were interested in to increase as well the value of the database. We've been following up mortality, and as you can see here in this chart, it is prevalent in our population, obesity, high blood pressure, it may be systolic or diastolic, or just the diagnosis of hypertension. And it is very interesting that our population, diabetes is prevalent, highly prevalent between 40 and 50 years old. So this age limit is the point where we have a huge risk of mortality due to diabetes in the population that we are studying. People usually is diagnosed between 35 and 59 years old with diabetes in Mexico. This is very frequent to be diagnosed in this age range. And in this age range as well, people with this diagnosis, they have a risk of mortality 5 times higher than the people without diabetes. People that are diagnosed or having diagnosis from 60 years old up to 54, they have a huge risk of having 3 times more risk of mortality. And as well, people that are very old, starting with diabetes at 75 years old, even they're going to be having a high risk at just a double risk compared to the rest of the population. If we see this mortality excess that is associated to diabetes, and we relate it with the mortality causes, the most frequent ones in the Mexican population, that would be, for example, kidney failure, heart failure, infections, neoplasm, cirrhosis, and some other diseases. What we can see here is that if we just get rid of diabetes as the burden causing, of course, the mortality due to these diseases, we're going to decrease a lot mortality due to kidney, heart causes. Now, in the population that we've been studying, and I think that throughout Mexico, it is even more important that the diabetes crisis. This is a topic that is very important, even for the health here in Mexico. Now, going back to the topic of this meeting, that is cardiovascular diseases, blood pressure. We see that blood pressure, maybe systolic, diastolic blood pressure, and as well the use of antihypertensive, if we have this high blood pressure that is diagnosed, is prevalent in the population that we are studying, without taking into account diabetes as an important factor. Now, if we set aside diabetes, if we control diabetes, here we see the analysis that is very common for people to have a high blood pressure in Mexico after 50 years old. Now, in these charts, in these logarithm charts, we see the relation between the usual vascular causes and the SVP. We could see that for strokes, the increase of 20 millimeters of mercury in the measurements is going to increase the risk of this mortality twice for every 20 millimeters of mercury. For the coronary heart disease, for every 20 millimeters of mercury where we have an increase of SVP, we have an increase of mortality, at least a 30%. And for all of the other cardiovascular diseases, the risk of mortality is going to be increased around 30%, only by increasing 20 millimeters of these systemic blood pressure. Now, I'm talking about systolic blood pressure a lot because we see a great relation with all of the other disease and these blood pressure, and I'm going to talk about this later on. Right now, I would like to see this opposite analysis. What would happen if we decrease 20 millimeters of mercury in the SVP? If we have, for example, that people have 20 millimeters of SVP, that is lower than the usual between 35 and 54 years old, it doesn't matter if they have diabetes or not, they have a risk at half the risk of the usual risk or the expected risk of dying. Then we have a decrease of 50% the mortality risk. So we have these between 54 and 64 years old, we have here a reduction of 40%, which as well, it is very important, and even a 30%, 20% between 65 and 74 years old. So it is very important to decrease the blood pressure, at least the SVP, around 20 millimeters of mercury in relation to the usual blood pressure. Now, when we see this absolute excess, it related to the vascular mortality that is related to blood pressure, and as well with the state of diabetes, we can see in this chart, this is not a logarithm term. Here we have the absolute excess. We have as well absolute increase. That is the risk of mortality. We can see that people having 135 millimeters of mercury and without diabetes, they have a mortality risk of 1. It means that they don't have a risk. That's the risk that we all have. But if we have an increase of threefold when we have this SVP that is increased, and when they have this SVP that is high and they have diabetes, there is going to be a double risk. Just by saying that it's going to be doubled, it seems that it's not that much, but as diabetic, they have mortality risk, although they don't have a high SVP of 4.5. If we have this risk of mortality at 9 times more, just by increasing the SVP by 20 millimeters of mercury, it is very important. Now, when we relate SVP, the usual SVP, and non-vascular mortality between the individuals that we studied, we find that, well, of course, kidney disease is associated. We understand that it may be that even the kidney disease is going to cause hypertension, but at the same time, we know that even hypertension may be causing this vicious cycle, having more kidney damage. It doesn't matter if they have diabetes or not, and we see that it's going to be impacted in the ESVP if we have infectious or hepatobiliary diseases. And as well, these respiratory diseases and neoplasm were not very impacted by this blood pressure. I've been talking about systolic blood pressure because we think that's the one that it provides more information, only if we measure one patient once. So in the case of a family medicine consultant, we just measured the SBP, and we found that it was the main predictor of a mortality due to a CVD, and as well coronary heart disease mortality. I mean, any type of CVD in all of the cases that we studied. And this diastolic blood pressure didn't provide a lot of information, and as well some other combinations of measurement of blood pressure and with pulse. In a certain way, they provided information, but mainly I think that it was due to the content of value that even this systolic blood pressure provided. So as a conclusion, we could say that in Mexico, it's very common to have kidney diseases, vascular mortality is associated to blood pressure, and as well, an excess of mortality associated to blood pressure is high in people with diabetes and without a good treatment. And in Mexico, it's even more important than in some other populations, just distributing more drugs and as well treatments, reducing the cardiovascular risk. And with this, I finish my talk, and then here we have the webpage of the article that we published. And thank you very much for your attention. Thank you very much.
Muchísimas gracias, doctora Alegre, por...
Thank you so much, Dr. Alegre, for this important Mexican study. Well, first of all, the moment it was published in Lancet and the second one in JAMA catches our attention. So I invite you to go over the studies. They are really, really representative of the cardiovascular epidemic and the determining factors. Also, that's why it really caught our attention. This is very important to profile the heart programs, both in Cuba and in Mexico. And now, I have the pleasure, the honor to introduce one of the persons that definitely have the most influence in the world of cardiovascular epidemiology in the world. She's a legend, Dr. Sarah Lemington. He is a professor of medical statistics in Oxford University, and I am really proud to introduce Dr. Lemington so that she can tell us what are the consequences in terms of policies and what are the key messages that these tests send. So Dr. Lemington, please go ahead.
Hello, my name is Sarah Lemington and I'm Professor of Epidemiology and Medical Statistics at the University of Oxford. My main research interest is in major risk factors for premature adult mortality, with a particular focus on tobacco, alcohol, blood pressure and obesity. I am also Director of Graduate Studies with responsibility for students on the MSc in Global Health Science and Epidemiology and the online MSc in Trials. I now want to talk about the policy implications of the findings from the Cuba and Mexico studies that have been so nicely described by Nuris and Hesse. I don't need to tell this audience that cardiovascular diseases are the leading cause of death worldwide, and with more than 3/4 of those deaths occurring in low and middle income countries. The World Health Organization estimates that about 18 million people die from cardiovascular diseases every year, with the vast majority of those deaths due to heart attacks and strokes. And importantly, about 1/3 of those deaths, about 6 million, are before the age of 70, losing many years of healthy life. But with modest lifestyle changes and relatively cheap and simple treatments, most of these cardiovascular deaths can be prevented. For example, in the UK, you can see here that in the 1970s, we had some of the highest cardiovascular disease death rates in the world, with a 35-year-old man having more than 20% chance of dying from cardiovascular disease before he reached the age of 70. But by 2015, that risk had plummeted to just 5% chance of dying from cardiovascular disease before the age of 70. And just note the scale here before I move on. Next slide, showing that unfortunately it's not consistently good news. So while in the 1970s, Cuban men had only half the risk of dying from cardiovascular disease than UK men, and Mexican men had even lower risk. And again, please note the scales here, now going up to 450 for Cuba, 350 for Mexico. But you can see that after 1970, unlike in the UK, both the Cuban and the Mexican cardiovascular disease death rates remained high, and indeed in Cuba until about 1990. And even once they started to decrease, they decreased more slowly than they had done in the UK. So that by 2010, a Cuban man had about a 9% risk of dying of cardiovascular disease by the age of 70, and a Mexican man had about a 7% chance. But worryingly, there's some suggestion that the rates, from these figures, that the rates have started to rise again since 2010 in both countries. But as we've seen today, the risk factors for cardiovascular disease are the same in these Latin American countries as they are in the UK and indeed the US and other higher income countries. And it's the similarity of these relative effects that's more remarkable than any differences. The obvious exception, of course, being diabetes in Mexico, which is not only more prevalent, but incurs a much higher risk, fourfold risk for a person with diabetes in Mexico compared with a twofold risk for someone with diabetes in Cuba. So while the most prevalent cardiovascular disease risk factor might differ between countries, whatever a person's CVD profile, lowering blood pressure and cholesterol, stopping smoking and losing weight will all reduce risk. And it's the results from the studies presented today from Cuba and Mexico that will inform health policy to address premature adult mortality in those countries. So how do we decide who to treat? Resources are limited. We can't treat everybody. How do we decide who to treat? Well, there is a lot of interest in developing cardiovascular disease risk scores, with 10-year risk being the most common outcome. But here, using data from the Mexico City Prospective study, you can see that these risk scores are really dominated by age, with most of the chart being green, yellow, or maybe orange before the age of 60, and for non-smokers even until the age 65. So with, for example, a 10-year cardiovascular disease risk of 15% as the threshold for initiating treatment, under the age of 50, only male smokers with very high blood pressure and very poorly controlled diabetes would be treated. And even up to the age of 60, only male smokers with all other risk factors at high levels would be eligible for treatment. And really, for a female non-smoker, then very few would be treated before the age of 65. Only the person with very high blood pressure and diabetes. So to try to address this problem, in the Cuba study, we explored a different approach by calculating first the chance of dying prematurely before, that is, before the age of 70, and also the average years of life lost according to a person's cardiovascular profile. So the two lines shown here compare in red male smokers with high blood pressure and diabetes, so-called high risk, and in black male non-smokers with low blood pressure and no diabetes, so-called low risk. And what you can see is that the high risk 40-year-old man has only just over 50% chance of surviving to age 70, compared with an 8% chance for the low risk man. For the difference in survival, we see a 10-year difference in survival between the high risk and the low risk men. In other words, the high risk men lose on average 10 years of life, and we saw a similar pattern for women. So I would like to finish with the following thoughts. All the existing risk scores are dominated by age, And the current policy of treating those at highest risk of a vascular event over the next 10 years results in prioritising those who are old, smoke, or frail. So, in other words, I will only prescribe you an antihypertensive if you carry on smoking. Not really the message we want to be promoting. Instead, I want to suggest that we treat those likely to lose the most quality life years due to a vascular event that occurs over the next 10 years. In this scenario, a 50-year-old at risk of a vascular event over the next 10 years will be prioritised over an 80-year-old, even if the absolute risk for the 80-year-old is higher, and that is because the 55-year-old will, on average, lose far more quality life years than the 80-year-old if they suffer an event. So to conclude, I want to suggest that we prioritise people at highest risk and who will lose the most quality life years. Thank you.
No, excelente presentación.
Amazing presentation that now will allow us to go with the 4 panelists at the same time. I would like to ask you to please open up your mics and activate your cameras to please introduce yourselves so that everyone can see you. And please be ready for the Q&A session. I am taking the questions from the chat, but I would like to invite you to please keep on entering your questions on the chat, because all of my colleagues behind the production team are collecting all of the questions that are relevant for our panelists. The first thing that I'd like to ask is Dr. Emberson, talking about these huge cohort studies, what is the consequence of this? What is the implication? How are these providing input today to the creation of risk scores that the WHO has been publishing lately? Please go ahead, Doctor.
Well, I mean, I touched on this a little bit in my presentation, and I think it's really not widely recognized how important the size of the study is with respect to the results it's able to produce, and therefore how reliable those results might well be for policy implications. So, why do we do it? Why were these studies 150,000 people? Why were they not 20,000 people or 10,000 people or even 5,000 people? And as I talked about in my presentation, you may, with a smaller study, be able to assess the average association between even an important risk factor like blood pressure and disease, but you really can't get to the level of detail you need to inform policy. So, when we want to understand the causes of disease, we want to understand the causes in different types of people at different ages. Are associations similar in men versus women? And it's really only by having these large studies in different parts of the world. We're very lucky that these studies exist in Cuba and Mexico. But of course, they're complemented by all of the other studies that have been done in other parts of the world. And the results for blood pressure, at least, are very consistent with results in other parts of the world. And this is wonderful. If you're a blood pressure epidemiologist, then interested in disease in humans, then you study as many different types of humans as possible. And I think these studies have demonstrated both the similarities of associations, such as blood pressure, as has been seen elsewhere, but also some key differences. So you can learn something about diabetes in Mexico that you can't learn by studying diabetes in the UK or in the USA, for instance. And so I think it's just to summarize, I think we're very fortunate that these studies exist. Their size allows them to produce reliable results, and because of that, I think they're directly relevant for policy initiatives in the area.
Thank you so much, Dr. Emberson. I think that We should also say right now that it is significant, the development of these two countries, Mexico and Cuba, following a 150,000 cohort for 20 years. It is quite significant. And this is also an example that is really worthwhile imitating and reproducing, because it is making the possibility of these countries to use this in the prevention of these diseases, right? So here we have the two leaders that today are implementing the cardiovascular health programs in Cuba and in Mexico. We will introduce them to you in the second segment. So it is very important that those that do research are very close to those that do health services, and those that are in charge of health services are very close to research, so that they know that the interventions that they are doing are based on evidence, and it is really worthwhile to keep on working like this. So I would like to now go to Dr. Armas in Cuba and ask her once again, what is the relevance? Look at this, just HEARTS is this program that we are carrying out in 16 countries, and I would like to welcome two new countries in HEARTS. We have Bahamas and we have Guatemala, and we are just receiving Dominican. This is country number 18, I think, or number 19, that's implementing HEARTS in the Americas. So Dr. Armas, Cuba is one of those countries that's implementing HEARTS. So one of the windows of opportunities that HEARTS has found in improving the diagnostics and the treatment of people with high blood pressure. And now you have even stronger data to advise your health ministries. What would you say about this? Well, I think that we are very happy, very glad to be able to, after so many years of waiting to have these results. We always said that we were very young when we started working with Dr. Dueñas. It's important to mention him because it was an honor to work with him for so many years, as well as Oxford team. And this work gave us the results that are so relevant and exciting, and especially because of the impact that it will have in order to be able to implement the public policies in Cuba, and to be able to especially address the efforts and the resources to those high-risk people. And we know that in Cuba, with this study, we will know how much it means to have a high SBP with 20 mmHg than what's normal. And we also talked to HEARTS team, Gabriel and people from Crónicas. We are so glad to be able to tell you that if you are diabetic, you have obesity, and you are hypertense, the cardiovascular risk is going to be this or that. And we are so glad, so happy to be able to show this and to be able to have our own studies. And thank you so much for inviting us to this seminar by HEARTS. Thank you so much, Dr. De Armas. It is truly stimulating to have this quality type of tests and studies, and it leaves us very reassuring with what we're doing. There was recently a study published about prevalence, treatment, and hypertension control levels in the world. And despite, studies, as usual, have a group where researchers maybe focus on one specific place or area, or the other parts of the study, and that's right. But in any type of evaluation, hypertension control levels are still ridiculously low in the entire world, just ridiculously low. For example, in Latin America and the Caribbean, only 35% of women are controlled, and 28% of men that are hypertensive, that have been diagnosed with hypertension, below 140. And we are even using the profile of 140/90. I just want to share this. Now, I don't really want to add more log to the fire, but this means that our programs are very far from being effective, and at least they're efficient. So that'll be all I want to say, because in the second part, we are going to be even more controversial. So now I'm going to go to Dr. Alegre with the data that he has given us. We knew that hypertension was a huge problem in Mexico. We knew that it is really a huge problem that Mexicans have, which goes back to diabetes and obesity. They are there with numbers that are just impressive in any type of measurement. And we have the study there actually. So there are things that, of course, hopefully Dr. Alegre can bring us to primary prevention, so we have less obese people and less diabetic and less people with hypertension, which would be great. And we have to emphasize, because that's where we need to have the most radical measures. However, what we're knowing now, Dr. Alegre, as you mentioned, a diabetic with hypertension or a hypertensive with diabetes mellitus increases the cardiovascular death rate amazingly. In your country, where you are creating a program so that most of the people can have access to it, what are the recommendations that you would like to share to your Ministry of Health based on this data? Please go ahead, doctor. You are muted, doctor, please. Thank you. Yeah, the mute syndrome. It's very normal, don't worry. So I think the main ones would be the indications that we shared in our presentation. We have to be very careful in Mexico with diabetics and with non-controlled and non-managed diabetics or poorly managed. And I think that it is very important to make drugs, antihypertensive drugs, accessible for everyone, as well as any other drug that favors cardiovascular health, for example, statins. I think that the main comment would be that we cannot really wait that during one administration we can change everyone so that it can be thin or they can change their lifestyle, but we can ask for people that are in high risk today to and in risk of losing a huge amount of years of life. It would be worthwhile to see them when they are young, because they, of course, face the risk of losing more years of life. Thank you so much, Dr. Alegre. Now we are going to go to Professor Sarah so that she can tell us a little bit more about what she was saying before. Dr. Sarah Lemington, please. Those who have high risk compared to those who do not have high risk, I mean, just in general, they have 10 years less of life expectancy. So what could we tell people then? Because HEARTS is promoting treating hypertensives, of course, and promoting a secondary prevention of a cardiovascular disease out of those who already have a cardiovascular disease, those who have a high profile of cardiovascular risk, and those who have a high problem such as chronic kidney disease or diabetes that can be complicated because of this. So what would you recommend, Dr. Lemington, knowing that people that are in charge of the Ministry of Health Services are coming? So what would you like to suggest our colleagues from Cuba and Mexico in the design of their programs of care? Please go ahead, doctor.
Okay, thank you. Well, I think one of the important things is about treating risk. So obviously someone who's already had an event, actually, do you even need to measure their blood pressure? Do you even need to measure their cholesterol? Just put them on a blood pressure lowering, put them on cholesterol, because as you saw from the figures, both from Dr. Alegre Diaz and also from Dr. Armas, that actually lower blood pressure reduces the risk regardless of where your blood pressure starts. So going from 160 to 140 halves risk, going from 140 to 120 halves risk. And so it's for those people who are already at higher risk, for example, because they've already had an event, or because they have diabetes, which puts them at higher risk of cardiovascular disease or renal disease, then these really are the people who we need to be treating first. And it is about treating risk and the number of years left that you can save, if you like. And so you can treat people with high blood pressure, but you'll save more lives by treating people with average blood pressure who've already had an event than you will by treating people with high blood pressure who have not yet had an event. But obviously the balance is that you don't want to leave people walking around with very high blood pressure, and I can see that that's difficult for the doctor. But I think it is about thinking about in terms of where do you spend your money to save the most lives, or to save the most years of life? And I think that was really what I was trying to get at, rather than lives as one outcome. It's actually, or the metric, it's about how many years of life can you save. And obviously blood pressure lowering is a cheap, blood pressure lowering, statins, aspirin, they're cheap, and we should be using them where we can. Thank you.
Muy bien, excelente. Yo creo que
Excellent. I think that this is just causing a great phenomenon. Now our panelists, experts in science and in academia, are going to hear those that are working in the science of implementation, which is not less important, how they break their heads in order to distribute the few resources in a most efficient way. I mean, it is the science of imagination and the science of implementation, which are two sciences. But before that, and thanking the first block, we will go back to the panelists of the first block at the end of the event. We are going to introduce now, do you remember that Dr. Sarah talked about the importance of cardiovascular risk and how it is assessed and how we measure it? Well, now I bring you some companies that have prepared for Heart's team and for the webinar the following. So Jenny, please go ahead with your gift for from Heart's team to all of our audience. Please go ahead. Steps to use the cardiovascular risk assessment. Please download the app from iOS and from Android, or use the web version. Read the brief section about optimizing the cardiovascular risks in patients of 40 to 75 years of age. Go to the instruction sections to familiarize with the table. Calculate the cardiovascular risk, and for this, select your country. And if you don't know your cholesterol values, select yes, no, and if you do, please select yes to enter the information. Click on calculate and you will get the results of your estimated cardiovascular risk, and then select on the recommendations.
Bueno, excelente, excelente. Esta es una contribución, quiero recordar esto, esta es una contribución de una diseñadora.
This is a contribution from a designer that we have here that is called Sandra Serviano, and as well from Jenny Rodriguez, that she is behind the productions organizing all of these webinars, and Andre Rosetta, a new cardiologist from Argentina that we have in our team. So, well, that's their contribution. And if you haven't downloaded this cardiovascular risk calculator from Hearts and the PAHO, because this calculator, besides calculating the cardiovascular risk, they could allow us to follow this measurement protocol to measure cardiovascular risk and to identify the specific protocol of the treatment that your country selected to treat people with hypertension and a high cardiovascular risk. So we are building all of these tools so they may be available for all of you. If you haven't downloaded your calculator, please do this. Our colleagues are going to show this, because we have as well the World Heart Day that is coming very soon. So if you would like to just give a gift to a friend or a colleague, send this calculator. As well, it's useful for general population. It's not for them to have just to self-medicate, but as well, it may be useful for a general population because they may be active in their treatment. Now we're starting the second section of this webinar, And today we're going to talk about the response. First of all, we saw the scientists talked about the risk factors, the importance they have, as well the frequency where we saw, and as well the risk, and as well just to outline the strategies that we have to follow. Now, I have the pleasure to introduce Dr. Yamil Valdez Gonzalez. She is the coordinator of Hearts in Cuba. She's going to talk about the program that they are doing in Cuba for its implementation. Please go ahead, Yamil. Hello, everyone. I'm greeting from Cuba. My name is Dr. Yamile Valdez Gonzalez. I'm the member of the National Advisory Commission for High Blood Pressure from the Health Secretary, and as well a technical coordinator from Hearts. I hope that you have a very fruitful exchange. So let's remember that Hearts has technical pillars for its implementation. It seems that we have a problem with the audio. We have a problem with this audio. We have a problem with this video. I would like to ask production, please, to correct this aspect. We have a problem with the video. Jenny, please, just let me know that we are paying attention to what is happening. We have a double audio in my computer. Could we start again, please? Because we shouldn't be having this. Remember that this is an online event, a live event, and the videos worked well, but now I don't have connection. Please, Jenny, just let us know. Yes, we are trying to check the technical problem that we have. If not, we could move on to Mexico, and then we're going to continue with the video from Cuba, or should we wait for a minute?
Yo creo que es mejor que pasemos al siguiente.
Let's move on to the next video, please. Are you sure? Yes? Yes, please. Okay, go ahead. Okay, I'm so sorry, but well, we're gonna go back. The company that is working with us is going to solve this problem, I'm sure, for this. Well, it's a shame because we were going to show the combination of the study from Cuba, what we were doing in relation to hearts. However, now just to be easier, just to make it easier, solving this technical issue, we're going to move on to talk about the case of Mexico. So I would like to introduce Dr. Ruli Lopez Ridaura, that is the General Director of the National Center for Preventive Programs and Disease Control of Mexico from the Ministry of Health in Mexico. And he's going to talk about what happens in heart in Mexico, how they are implementing hearts in Mexico. Go ahead, please, production. Good afternoon. Good afternoon, all of you. Thank you very much. I would like to thank PAHO for organizing this virtual event that is Science in Action for Better Cardiovascular Health, where we were invited here, colleagues from Cuba and as well us from Mexico, just to talk about the progress that we've had in the implementation of hearts. I would like to thank not only for calling us to this seminar, but as well for all of the support that we've had from all of the PAHO team from Washington and as well locally here in Mexico. For the implementation of this great project that we consider this is a transforming project. And that's why from the moment that we saw this project a couple of years ago, we took it as a core of transformation. So today, I would like to talk about the progress and the great challenges that we've had, that we faced in this implementation. So this is my presentation. So throughout these slides, we're going to be showing what we were asked to present to all of you, the progress that we've had in the implementation of HEARTS projects in Mexico. And I would like to start talking, first of all, talking about describing as well the most significant goals or achievements that almost 2 years where we started this HEARTS project in our country. And one of the aspects that we think that is a great achievement is that we used the HEARTS project as the public policy for the prevention, care, control of cardiometabolic diseases. We've expanded our central approach of hearts in hypertension, and now we have it in a more general aspect of cardiovascular risk, and in particular with the inclusion as well of prevention, care, and control of diabetes, which is a huge problem in Mexico. And not only that, but as well within the process of transformation of all of the health systems in Mexico, that from this administration, we established the commitment of a new health system with a clear approach to primary health care among all the different stakeholders that we are transforming the opportunity of having the HEARTS project as a dynamic project, the project that is providing a technical substance to all of the transformation component. And I think that this has included and had just added all of the stakeholders from the health system in Mexico in this project. And that's why, well, it's very interesting. The other achievement that we want to talk about is training. Thanks to the support with PAHO, we've created information throughout the different HEARTS modules, and we established a group from the center that I'm guiding, that is the National Center of Preventive Programs and Disease Control, and we are the leading group of the HEARTS program in all of the states of the country. And in this group, together with some other colleagues outside and advisors and colleagues from other institutions, in order to have an important intensification of training all of the healthcare professionals throughout different components, but in particular in two aspects of HEARTS that we consider key for the transformation, that is in the proper measurement of BP using the proper inputs, but as well throughout the protocol that we've had in the treatment and in the new treatment for blood pressure with a new therapeutic guideline. That's exactly the third great achievement. As how it may happen in different countries, all of these treatment protocols are different, and as we see the different guidelines of care in Mexico, we notice that we didn't have a standard process for treating a lot of these diseases, and in particular, these major diseases, diabetes, high blood pressure, dyslipidemia. So we started a process that is called triple optimization, where a group of experts get together, define the best treatments that they may have the higher impact in cost and effectivity for the population. And then we saw this in the optimization of the next phase, that is in public health, just to see the demand from the sector, the demand from the health sector that we may have in a few treatments, and as well we may take it to a consolidated purchase. And that's exactly what we've been trying to do with a consolidated purchase, just to ensure the supply of medication. And an important thing of this treatment, which was also part of the HEARTS initiatives from its beginning, was exactly having a clear protocol, a clear algorithm of treatment, and as well of the dosing of the treatment, that for the specific case of high blood pressure, we have this need. And most of the patients requiring dual therapies to have the combination of two salts, and then they may have the necessary dosing to decrease the other problem that we've had in the treatment of this type of diseases, that is a clinical inertia. This was complex. We have to have agreement with different stakeholders, with different institutions from the health sector. As you know, in Mexico, we have a fragmented system, and we could reach agreements in the different expert groups, clinical groups, and as well the management groups that are part of the consolidated purchase of medication. And the last one as well that we're working with is in an official norm for standardizing these sphygmometer that are automatic and as well mechanical, because one of the great challenges of measuring these blood pressure is that the tools that usually are applied, they are not the proper one, they are decalibrated, and that's why the measurement of the blood pressure has been a huge challenge and a huge problem in order to achieve the control and, of course, to take decisions. One of the other things that I would like to talk about is when we started implementing HEARTS, when we started planning its implementation throughout the different states of the country, well, we were experiencing the pandemic, and after 1.5 years later, a lot of this project of implementation, as you will see in the next slides, was stopped. And of course, because of what happened throughout the world, just to provide more attention to treat COVID. But we learned something in relation to the application of HEARTS during the pandemic. We had this ZAVI model, that is the transformation model of the APIs that we have in Mexico, primary healthcare in Mexico. We combined it with the HEARTS model and with a model that we implemented in particular for the COVID, which was called the COVID community, that had the purpose of looking for patients with respiratory symptoms to have the diagnosis and to identify those patients with a high risk that needed a more intense approach, or as well with an hospitalary approach, because we saw that the problem that we had, that we still have, is that patients arrived late to this hospital care and with a very low possibility of recovery. And then we had to establish a mechanism which was not exactly formalized in Mexico in any of the sectors, which is the community component, going household by household, looking for patients, looking for risk groups. And that's exactly what we want for the HEARTS project is needed, to go out, to look for patients in the community, those patients, to identify the barriers where they are not going to the health centers. And that's why adding HEARTS in these community brigades was useful as a first step in order to make this primary care level with the community approach. Since the beginning of HEARTS in Mexico, this is the map of the country. And as well, we have 2 states in green, one at the north, that is Sonora State, and one at the southeast, that is Chiapas State. That's where we started the implementation of HEARTS. And we started with 41 units in Chiapas, Sonora with 36 units. That's how we started. We started with 29. It was expanded to those units that I already mentioned. And throughout the states that we have in yellow, those are 11 states, we started in the pre-implementation phases in 230 units. And besides, in the 2 states in yellow, in orange, in Quintana Roo and Colima, we have as well the desired management to start. As you can see, we've been covering a huge amount of the country. So what's the plan to expand towards 2024, 2025? That's the commitment that we have for our administration that is going to finish. This administration is going to end in 2024. And the plan that we have is that by the end of 2024, we're going to be able to have at least 70% of all of the primary healthcare centers having HEARTS. In 2021, we have 600 that are in the implementation or pre-implementation phase. And for the next year, we want to add 4,300 units. And as well to be able to continue expanding up to reaching 2024 to more than 8,000 units. And something that we're working on, that is to add the Mexican Institute of the Social Security in one of its components, that is for the open or general population having more than 3,000 units, and as well to be part from this moment as part of this transformation process. And besides these 8,400 units, in the process of 2023, we may include 3,000 in addition for that for people that they're not exactly patients from the INS, that is the Mexican Institute of Social Security. And the challenge that we have in this implementation process, the problem that we have in the healthcare, in primary healthcare institutions in the country. Here, I'm just showing the example of Chiapas and Sonora, and those were the first states that we started working with. And if we estimate the prevalence based on the data that we have in our survey, out of this population of 20 years or more living in the area of coverage of the clinics that are already added into hearts, we have a high prevalence of high blood pressure, which means an important number of individuals having high blood pressure. And when we see the patients that are giving a follow-up that are in the health centers, well, we see that coverage is too high, 4.8% and 5.1%. Out of these patients, I think half or even lower, they are in a control. When we see at the level of population, we have a 7 and 2% of the patients that we should be noticing, detecting, and controlling, which we are not doing. And this is the challenge that we have in the implementation of hearts. How can we do it? That is one of the great challenges. And for those patients, just to provide them healthcare, follow-up, and control. And that's exactly why we have those indicators that are key to see the progress. As I said before, one of the things that we've been strengthening the situation, because during the pandemic, it was a little bit difficult having this strengthening of the implementation of hearts throughout the clinics. We provided a lot of remote healthcare and all of those strategies that probably in so many places of the world were already implemented. What we were able to do was to make progress in the training modules. We have these 4 modules that we gave with the support of the PAHO, and as well during this, we started with the basic aspect with the prevention in the primary healthcare in January. That's when we started. And during 2019, we added another module that it was a technical package of all of the different components of hearts. And the last 2 modules that we added is exactly the management, the clinical management, and with treatment, that is the pharmacotherapy for the high blood pressure, and as well for the precise measurement for this amount of people that receive the training. In this first quarter, where we identified we have 17,000 new people that were trained with these different modules throughout the country, and in particular in Chiapas and Sonora, which are the 2 states where we have this approach because we already implemented, or where we are in an implementation phase. We've covered all of the personnel having direct relationship with patients. So throughout the different modules, receive this training and we provide those certificates. Certificate A, those are for the staff having a direct relationship with patients, and certificate B, which are also important, and they are for all of the people involved in the management, promotion, in the more administrative or technical administrative part that would allow us to give follow-up. And we believe that this is a great achievement to cover all of these personnel, which of course is physicians, nurses, health promoters, nutrologists, dietists, psychologists that were trained in all of these different courses or components of hearts. Lessons learned, and this would be the last part of my presentation. I would like to highlight from our perspective the factors that supported this implementation. A very important aspect is the commitment, the political commitment, and having hearts as part of the priority agenda, not only in the National Plan of Health, but as well in the process of transformation. And when we go with our stakeholders at a local level, this has been useful to promote it, and for them as well to consider these as state priorities and not only federal priorities. And another important aspect is the engagement that we had with an intersectorial group, and as well to promote hearts, and as well to promote a lot of what we are doing, we've had this important collaboration with the academy, NGOs that helped us promote this process, but as well we've included some other sectors, and not only the health sector, to continue working in the important determinants that we have for chronic diseases in this food environment and in this other environment, that if we don't modify that, it's going to be very difficult to achieve a substantial change in the risk of these type of diseases. And the other aspect is the need that we saw from the beginning, that is being able to have a collaboration and coaching of the primary healthcare personnel. We think that training is a very important aspect, but that is not enough. At the end, the primary healthcare personnel need a continuous support, and we've established these local groups that could allow us, in the case of the clinics that are part of HEART, to have as well clinical mentors that could help them in the decision-making process and in the continuous education that they need. So what are the factors that have been hindering the implementation that we identified as barriers? One aspect which was complicated because, well, we have never thought about the fact that we need to ask a diagnosis of the coverage region, and it was difficult to establish a standardized way of understanding real conditions in which the needs of the population that they're going to be providing this service. And I think that this is one of the huge challenges, that if we don't start with a clear baseline diagnosis of the real need of the population, it's going to be very difficult to have an impact, because we're only going to stay with what we can see, but not with the real need. And we've been promoting this, we've been standardizing these diagnoses, and we believe that this is one of the key components. The other aspect is that these type of training courses, they are not going to have a continuation, and as well we've been emphasizing on the local sectors that we don't have these, if we cannot provide these training courses with all of the modules, it's going to be very difficult to achieve the proper implementation. But probably the most important challenge, and that's in bold, it's the supply. We have an important problem of consolidating this demand, of having these consolidated purchases, and to ensure that we have treatment in the primary healthcare. We had this historic inertia from several years where we had this type of low quality medication in the primary healthcare, and it seems that those medication with higher quality, more efficient, may only be used by the personnel with more training, internal physicians, endocrinologists, cardiologists, when it's the opposite. So transforming these and sending the medication to the primary healthcare level, of course, it's a complex logistic. It is different of what we've been doing before, that we've been doing for so many years in the health system. And this causes that we're not going to be able to start a process if we don't have the medication or the supply or the inputs. That is, for example, having good gauge meters, digital gauge meter throughout all of these centers. The other challenge is record. We are modifying the recording system and the platforms that are being used, because one of the most important problems of this platform is that when the platform is not going to be useful for the health personnel that is making decisions, it becomes an administrative burden where we need to we need to record how they need to see this in a different moment where they're going to be making decisions. We've been trying to have the information and the indicators that we are requesting as follow-up indicators would be exactly the ones that may be useful in this platform, and platform that may be useful for the physicians that just make decisions, to be a useful tool, and then as well the way in which we record information. We are just about in the middle of this process, and I hope that in the next months we already implemented a good information system that could allow us to have real information, more real information, and useful information for all of the different healthcare levels. And this has been a huge effort from all of this team, of course, from the team in Washington. This is the first picture when we opened. When we opened with this project, just for the support of the PAHO and as well all of the visits that we've made. And thank you very much for the Senaprese team and as well from the center that I lead by the leadership of Laura Gloria, and as well the team that has been working in each one of the states. And this is just a couple of the pictures in relation to the training courses, the visits, and as well oversight. And that would be the end of my presentation. Thank you very much. And I'm here if you have any question. That's excellent. That's an excellent presentation. And I think that here in Mexico, we are just being informed of the good practices of just to implement this program. And I would like to talk about two aspects. That is primary health care. Again, primary health care, because HEART was designed as a primary health care program, of course, with the participation of the health team. And then we're going to have a conversation on one-on-one on what the people doing science in the academy and then what they work with the implementation. But I would like to say that HEART is a huge place of research. In fact, the countries that are implementing HEARTs, one of the requirements is to have a record with patients with high blood pressure. So after listening to the speakers from Oxford, Cuba, and Mexico, now without further ado, I would like to give the floor to the next speaker. That was the video that was having problems. So Yamil, go ahead with the presentation from Cuba.
No tenemos audio, por favor.
We don't have audio.
Estoy revisando todos los canales y no encuentro el audio, por favor. Si me indican si tenemos audio, por favor. Sí, nos están indicando que no se escucha el video tampoco. No se escucha el video, por favor. Los colegas que están en la producción que indiquen cómo nos movemos con esta nueva dificultad. Esta nueva dificultad yo les pido, por favor, que la solucionemos o que me digan si estamos en condiciones de solucionarla, porque es una pena perder esto. Yo creo que también teníamos a la doctora Yamil del otro lado allá, por si acaso fallaba la presentación. Pero quiero preguntar, Jenny, por favor, ¿me puedes dar dar una señal de qué cosa está pasando ahora mismo, por favor?
En este momento el equipo técnico está tratando de poder solucionar. Yo me voy a quedar como cojo para ver si desde mi computador puedo pasarlo, porque parece que ellos no pueden pasarlo y también activar los audios al mismo tiempo. Entonces voy a intentar pasarlo yo a ver si nos funcionan los audios. Nos dan un momento.
Favor, por favor. Ustedes disculpen esta interrupción. No pasa con frecuencia, pero pasa en algunas ocasiones. Lo único que se me ocurre es preguntar si tenemos a Yamil todavía en línea y si tiene la presentación a mano de que... Sí, ¿ya estamos? ¿Ya estamos? Por favor.
Hola Pedro, estamos acá esperando. Hello Pedro, we are waiting for the solution of a technical difficulty, but if it's necessary, we can do it here.
Okay, vamos a ver. Por lo menos empiezo a ver la presentación. Ahora sí, adelante.
Hola a todos. Un saludo desde Cuba.
Hello everyone from Cuba. I am Dr. Yamil, member of the National Commission of Hypertension. Hopefully, we can have a very fruitful exchange.
Recordemos brevemente que HARTS.
Let's remember that HEARTS is one of the fundamental technical pillars in the Americas. In this slide, the main progress in Cuba is summed up. Heart's technical pillars were done as of the world measurements, but also considering Cuba's ones. The proposed activities, I'm sorry, I'm having a very hard time listening. I can't really hear, but I'm going to do my best. In this way, Hart's model is introduced as an update for the current hypertension measures, which is the basis of the actions for the Ministry of Health. At the beginning, there was a dramatic change due to COVID-19. Up to 30 of August 2021, 646,513 cases were diagnosed. Between March 11 and October 15, 2020, more than 47% of deceased due to COVID were hypertensive. Other described comorbidities are associated with a major mortality: diabetes mellitus, obesity, and previous cardiovascular disease. The increase in hypertensive people diagnosed was because of different causes: cardiovascular risk stratification, vulnerability criteria, arterial hypertension, established assistential protocols, and procedures for clinical research for vaccines and vaccine candidates. Out of the vaccine candidates, 3 of them are already registered as feasible vaccines. Initially, during the pandemic, Hearts vastly contributed in providing a protocol, a anti-hypertensive protocol, as part of the national protocol used in all of health systems and units. And this allowed a faster response when an emergency need for help by hypertensives. New distribution strategies for drugs were created in order to assist patients in risk.
Y también se plantearon nuevas estrategias de distribución pensando en acercar los servicios al paciente, a la casa, a la comunidad, en que se proporcionaron los fármacos a estos pacientes que se encontraban en aislamiento y constituían grupos de mayor riesgo y vulnerabilidad.
And these drugs then were sent to the patients that were under highest risk. At Hearts, the strengthening of the training of the basic teams of health was one major goal, and also they prepared the clinical validation studies in order to be able to carry it out properly, and there was a coordination to modify the regulatory framework. And the attempt here was getting data. Hearts addresses 500,101 adults, and out of them, 62% are accepted and treated as hypertensive in the last year, and 44% of those older than 18% are also under populational control. This represents that the shared results are specifically relevant if we consider the deterioration due to the pandemic, which caused drugs limitation and constraints. And another consequence of the epidemic that has modified
y los hábitos de vida de los pacientes.
Lifestyles of the patients, of the people, as of physical and social distancing that the pandemic caused. In 2020, Harrods implemented 20 health centers in 5 different municipalities. By 2025, the expansion will include 15% of primary health services. Considering the characteristics of our health system, maybe by 2025, we will be able to see what center does better and what center is missing for implementation. The lessons learned have been many. However, we want to emphasize on the ones that are going to constitute the basis of sustainability for the years to come. In these places, the creation of new health centers has allowed us to follow protocols and the decision made by experts. Among them, we have the development for the production of drugs and the design of validation studies as the country is able to produce them in the primary health assistance. We have also strengthened the technical capacities, which is an indispensable element to guarantee quality in processes and results of intervention. And there has been a systematic training process for the teams involved, with doctors, nurses, and other health professionals that are incorporating. And this has allowed to increase the quality of the processes that we are implementing. Also, we have worked in modular events in order to be able to monitor the progress and know what is going on. And the fact that implementation sites has increased, we have been able to offer sustainable changes that are led by systems designed by ourselves. Hearts in Cuba projects on a scenario affected by COVID-19. From the beginning of the pandemic, health centers have focused on treating the community and keeping basic services and health interventions, as well as the massive vaccination of the population. And the Ministry of Health in Cuba has allowed us to give important steps towards HEARTS program implementation. We have worked with the Ministry of Health in Cuba so that HEARTS becomes an important part of the response. And last but not least, I'd like to say that HEARTS in Cuba has many challenges. From the doctors and the nurses and the basic members, rehabilitators, pharmacists, psychologists, and other health professionals, students, academic society, civil society, patients, their families, constant renovation and the possibility to adapt to changing situations have been aspects that have allowed us to guarantee the continuity of health services in this new context. Hopefully, the shared experiences can be useful for the problems that the region faces. Thank you so much for your attention. Thank you so much, Yamile. Thank you, my dear colleague. Well, we've heard Cuba's and Mexico's presentation from those who lead in hard implementation in Cuba and Mexico. So I'd like to ask for all of our panelists in the first segment and the second segment to turn on your cameras, and now we will start a conversation among the two groups and the two sessions. We understand we're talking about the same group, basically, right? But I would like for us, for everyone to please turn on our cameras. I ask Dr. Jonathan and Dr. Sara, Jesus, Dr. De Armas, Dr. Yamile. And this is a great discussion opportunity. So I'm going to share the first question. I do not see Dr. Ridaura on the chat, but I wanted to start with Mexico. So if Dr. Ridaura is in the room, please, I don't see him on my screen, but maybe, yeah, maybe he had to leave and we will have Miguel Diaz. Oh, Miguel Diaz, please go ahead. But in the meantime, Yamile, so you are very fortunate because Yamile and Alma are together in the same place in Cuba. Yamile, so what do you think about the Dr. De Armas presentation and how useful is it for hearts? What you are just listening from the people that's doing science and that's finding out what is the prevalence and the impact of those risk factors in Cuba. Please go ahead. Hello, everyone. First of all, in Cuba, this huge study has been a very important factor, but also our health system conducts these advising technical measures that include ischemic heart disease, diabetes, hypertension, chronic renal disease, and the scientific society, in this case, the Cardiovascular Society, has played a fundamental role in the conduction of the process. So we have research projects as well as the academia included in the entire process, which supports and certifies that knowledge transfer from the tertiary health services or the attention towards health services. So changing systematically with primary attention, being able to exchange information with them as well as medical guidelines is a strong point. And having these studies are a reference for decision making at a central level. And so in sort way, we can convince of the needs for change. So it has been a policy working interconnected from research, from innovation, from academia, from colleges and universities that are cooperating with this effort. In order to socialize these results so that implementation flows in a way that you don't even feel that it is a project. What we are perfecting is our daily work. So I think that this is going to play an important role in the research. And we said that in 2019, for Lancet, this has been fundamental part of the publishing. Thank you so much, Yamile. Now that we have Dr. De Armas next to you, maybe the question is kind of embarrassing, but I'm going to ask it either way because it is the question that we have here. How? So you have produced a result, a research result, right? That has had a huge relevance in the main journals of the world. Do you think that these results are taken into account the daily practice when managing health programs around the country, or what do you think? Well, these results are being taken into account and the Ministry of Health, from the Ministry of Health and the Department of Non-Transmissible Chronic Disease, there is a lot of joy to be able to have these videos and share the impact that we didn't have before. We didn't have these results before. So now we can talk about our own results. So we are very excited to see that this happens with a person that smokes, that's diabetic, that's hypertensive. And when they shared all of those factors, what happens then? Well, the academia and those who implement policies are all working on how to use these results. And the first implementations actually about the results are already being elaborated. So actually the other academia, which is the National Institute of Biology Engineers, and researchers worked with us in this research, and the Institute of Endocrinology also participated in this research, and their result is working for new policy implementation. And talking about hearts and talking about COVID-19 times, well, many times we go back to analyze the results that we already have and the people that are in higher risk, because we need to know what kind of people are dying during this pandemic. So through this pandemic, we can see who are those higher risk individuals. Thank you so much. I just wanted to share one message again, which is not light, is something strong. Invite people to use the data of the research so more informed health services can be created, and also use the capability of the research to support implementation programs and assess how well we are doing. So in this sense, I would love to hear Dr. Lemington, please. I don't know if you had heard along with Dr. Emberson, because we have an audience that's joining us today, Hearts audience. The people has been getting used on how Hearts works, but I don't know if you had heard about Hearts before. However, they're seeing what are the modular points that we are putting on the table, and we already heard the experiences from Cuba and from Mexico, and I'd like to know your comments from Professors Jonathan and Sarah Lemington. So please, Dr. Lemington, go ahead.
Thank you, Dr. Ordonez. I think the main thing is that we've seen today how, as you've said, how research and policy need to come together, and that these two studies really will influence policies not only in Cuba and Mexico, but around the world. And I think that's the main thing, and that I put in the link that there are other studies around the world in different parts of the world. And again, kind of as Jonathan said, Jonathan Emberson, you know, it's about looking in populations with different levels of exposures, or with different exposures and different diseases, that only then are we really able to look at some of these associations in proper detail. And we find out things in one part of the world that benefits the rest of the world. And I think that's one of the real strengths of these collaborations.
I just agree.
Excelente. Dr. Emberson, adelante.
Yes, Dr. Emberson, please go ahead.
Well, I was just going to agree with Sarah. I don't really have much to add to that, to be honest. I mean, we've been doing epidemiological studies for around over 70 years now, learning about the major causes of disease in different populations, whether that's smoking or blood pressure, or adiposity, diabetes, alcohol consumption in particular populations. And I think the strength of these studies combined for major risk factors like blood pressure is really demonstrated, today with these two cohorts from Mexico and Cuba. There's so much that you can learn from other populations, but actually having this direct evidence in these two countries, in these two populations, I think is really critical to be sure that the local policies are the correct ones.
Can I just add one more thing that sorry, I forgot to say, is just the huge amount of work that is required for these studies, and that we shouldn't underestimate the work that Dr. Armas has done with Alfredo Dueñas, who set the study up in Cuba, but equally Jesus Alegre and his colleagues Roberto and Pablo in Mexico. Really, it's a huge amount of work. It's 20 years of work, and only now are they really seeing the benefits and the fruits of their labor. But fantastic studies that they've performed over those 20 years and will continue to get results from, benefit from.
Yo quisiera pasarle
Thank you so much, Doctor. Now I would like to pass this small vaccine, now that we are talking about vaccination, with our colleagues of Oxford and our researchers. Please think about this for a moment. Hearts in all of the health centers that they are implementing. Now we have 16 countries, almost 800 health centers for primary care, between 20 and 30,000 people that are implementing the initiative, that have patients registered, more than 500,000 of them. Let's think about how science and academia can add to hearts programs and start studying the patient's records with all of the characteristics in real world. I think that these patients' records are a very powerful weapon. Countries are progressing in informatizing the records, and I think that this is going to enable us to do many things together in the future. So now I would like to pass the floor to Dr. Alegre. So what is the reaction of what you heard and what implementation is doing in Mexico? What can you tell us about that, Doctor? Please go ahead. Well, I find it very good, Dr. Ordóñez. I think it is quite amazing to see that measures are being taken and that they are reaching to the lowest level of medical attention in the country. I find it very interesting because the first level of attention, as it was mentioned during Dr. Ruiz's presentation, people wouldn't receive the drugs that were destined to patients, or to patients that were seen because by the third level of attention in the country. So I find this change to be very reasonable and very positive. And I think that hearts implementation in Mexico is proving a very reasonable progress. And hopefully in the future, I can see changes in the population that we are following ourselves. And this will be reflected only by studying it. Great. Actually, we have Dr. Miguel Angel Diaz. He is at the Ministry of Health in Mexico, and he's in charge of hearts implementation on the field. So Miguel Angel, what do you think about Mexico's results and the cohort study results in Mexico? And how do you think that hearts is absorbing this information? How are you using it? Hello, everyone. Hopefully you can hear me because I was having problems with my connection, my internet connection. Well, the results are very encouraging, definitely. There has been some progress. Dr. Ruiz was already mentioning the barriers that they have seen, but I think that some of the most important lessons learned during the pandemic is the urgent need to strengthen the first level attention. And this system needs to be strengthened not only in attention, but also in service comprehensive networks, because without them, very hardly we're going to be able to answer during a pandemic when we have so many populations affected. So one of the most important aspects that we have to take full advantage of with this that has been implemented during the pandemic to strengthen the action that's close to people and to keep detection and monitoring of metabolic diseases. And on the other hand, to address COVID. So these community and specialized strategies are one of the components that without a doubt, after the pandemic, we need to keep and reinforce and we need to do it promoted by HEART's implementation. And coverage, I think that it has already been explained by Dr. Rui. It is not what we would want. However, we are working hard so that before the year is over, we can accelerate the incorporation of these entities, 11 of them states, that virtually are done on the implementation process so that they can start operating hearts in the units that are already. Because actually we see the training numbers and most of them, if not everyone in those units are trained and are ready and willing and eager to start working with the implementation of the package. And not only the pharmacological aspects, but also one of the works that we have been stressing on every time we are with the different states is that hearts also came here to strengthen the other part, that many times that part of the treatment is believed by health professionals and by patients that is optional, which is a non-pharmacological treatment. And without a doubt, it is crucial so that the goals are reached and the expected results are also obtained. Very well. I always have a lot of questions on the chat, and I cannot tell you that we can continue because time is running out. But I was asking Miguel Angel that with this data that had been presented in Mexico, that Dr. Alegre has just presented, well, if you have hypertension and diabetes, look at what's happening with mortality rates and the huge prevalence. So the important thing here is how you can keep close so that the implementation and policy that we are implementing in hearts are close to what science are giving us in terms of scientific evidence in order to reinforce these programs. I have someone here that's very dear to me in our region, Beatriz Jampan. I'm sure that you know her, Beatriz Jampan. Beatriz is always very aware on how we can move forward. What are the main obstacles that we have in the region for the treatment of hypertension that could make us have further progress? I think that we are going to, I'm going to summarize this, but let me just give me some numbers so that we can leave this with information. Only 35% of women and 23% of men have a controlled high blood pressure. 30% of women with hypertension is not diagnosed by the system. They do not know that they have an altered high blood pressure until they get a stroke. And 43% of men do not know. And of course, we are saying something in hearts that's very important. The coverage is the indicator, one of golden indicators by hearts. This means access. If in countries coverage of the program is low, then this just means that there is a lot of people without care for whatever reason. So the programs would have to aim there. And when we say that control rates are very low, then this also means that the country of the countries or the health centers are not being able to meet with the minimum treatment standards so that those in treatment can consider control. So I'm just want to leave you with this because in the next hard webinar that's going to be on October 1st, please write it down. We are going to regionally launch the new hypertension guidelines by WHO. October 1st, the regional launch of the new hypertension guidelines by WHO that showed us a lot of things and now that we have to implement. Last but not least, I would like to thank all of our speakers. Please turn on your cameras for our production and the interpreters, everyone that's behind this, as we always do for the family picture. Please go ahead.
Ella es la que hace toda la coordinación de esto. Me imagino que
She is in charge of the coordination of all of the things. I think that after this, she's gonna go directly to bed because she's being very tired. It's very difficult to organize this. And I would like to introduce as well all of the translators, interpreters, and as well the administration team and the heart team that is behind all of this. And of course, I would like to thank our dear colleagues from Oxford that they are there. I hope that you've had a great webinar, and I hope that we could continue, Dr. Sarah, Dr. Jonathan, just to continue in coordination. We're going to call you again. We're going to call you from heart for you to continue working with us and just teaching the best science as well to our health teams. So here we have Gloria as well and Arantia. I don't see you over there, but probably you are over there. As well. So let's take this family picture just to finish our webinar. Angelo as well, you are there. And I see Elena. I see a lot of people here in my screen. And I would like to congratulate everyone for this webinar. I hope that you've spent a nice afternoon and that it was this time that you spent in listening to this webinar were great. And again, let's watch the video that Jenny and Andres prepared for the audience. So see you soon. Have a good evening or good afternoon. And we're going to see you soon in the next webinar of Hearts, that is October 1st, 2 p.m. for hypertension guidelines from the WHO. So go ahead, let's watch the video. Thank you very much.
Ahora no tenemos música, pero supongo que pongan
Well, we
música.
cannot hear the music, but probably we're going to listen to the music very soon.
Hasta luego.
Goodbye.
Jenny, gracias a este video tuvimos más de 1000 personas que bajaron la aplicación en esta hora desde que presentamos el webinar. Así que valió la pena, colega. Muchísimas gracias a todos, Andrés, Jenny, el equipo de intérpretes, el equipo administrativo, todos muchas gracias. Felicitaciones por los resultados y nos estamos viendo en el próximo webinar. Hasta luego.
Chao, hasta luego, gracias a todos.